Secret number 4, do a formal gait analysis. Let's repeat that. Do a formal gait analysis. Now, let me ask you, raise your hand if you indeed do a formal gait analysis. Yes? No? Do you do that? Raise your hand if you do some sort of an informal gait analysis. Yes? No? Do you do a gait analysis even though it may be sort of informal? Or raise your hand if you don't do any kind of a gait analysis. And I have to admit that for the longest time I was in the third category of doctor, in that I did not do a gait analysis as part of my routine examination, because, as I said earlier, in the clinical setting in the chiropractic office, a gait analysis was just not part of our protocol. And so I was largely unaware of gait analysis and how to do a gait analysis, and I was even ignorant of observing gait, because it just wasn't something that was part of my routine protocol. But I became aware of the importance of the gait analysis increasingly as cover letters began arriving on my desk from attorneys, applicant attorneys, and insurance companies requesting comment about permanent impairment related to gait, specifically by analogy after the advent of the Alvarez-Guzman 2 line of cases. I started seeing cover letters showing up on my desk with specific mention of permanent impairment by analogy to gait. And so I had to admit to myself that I didn't know how to assess gait. And so I went through quite a bit of research on what constitutes normal gait, what constitutes pathologic gait, and how to actually conduct a substantial gait analysis that qualified as substantial medical evidence. And I created a program. It's a 3-hour program. It's entitled Gait Disturbance and Assistive Devices, and that's available on our website. It's a 3-hour program. It's approved by the Division of Workers' Compensation for QME Continuing Education Credit, and I recommend the program highly. It goes through a simple procedure that you can use in your face-to-face evaluation of an injured worker to capture any disturbance in gait that may qualify for permanent impairment. And the beauty of it is it allows you to capture on videotaping your findings. You know, it's said that a picture is worth 1,000 words, and a videotape that supports your opinions and conclusions certainly has to be worth many more than just 1,000 words. And the procedure for conducting a formal gait analysis is described in its entirety in this 3-hour program, the Gait Disturbance and Assistive Device Program. For those of you that are watching the PowerPoint presentation with this program, the PowerPoint presentation contains 3 such videotapings of actual injured workers. These are videotapes from my library, and the videotaping demonstrates 3 injured workers, each of whom qualified for permanent impairment due to gait disturbance. And the videotape is quite enlightening because it shows for all to see the gait disturbance, and it captures it in videotaping. And the videotapes show you each injured worker from 3 different angles. There's videotaping from the front, from the affected side, and also from the rear. And that's on the PowerPoint program, so you'll want to watch that. That is beginning on PowerPoint slide number 82 and continues through PowerPoint slide number 95, and shows the animation of the videotaping and also my narration of the history of each of the injured workers, and also the significant gait findings which you will be able to identify. Without a full discussion of the topic of gait, which we don't have time for in this program, I refer you to the 3-hour program that I was referring to. Before we leave this discussion of this exam secret of the most persuasive QMEs, I just want to give you a little homework assignment, and that is for you to go to chapters 13 and chapter 17 and go to the tables in those respective chapters that discuss gait disturbance. In chapters 13, it describes disturbance of gait associated with neurologic disorders, and chapter 17 describes gait disturbance related to disorders of the lower extremity. And your homework assignment is to become familiar with which impairments, number one, require an assistive device, and number two, which impairments require an actual observation of the gait. Of all the impairments described in chapters 13 and chapters 17, some of those permanent impairments do not require you to actually observe the gait, but some of them do. In other words, in order to conclude that your injured worker has a permanent impairment, some of the impairments require that you conduct a formal gait analysis. And so the program, the 3-hour program, the Gait Disturbance and Assistive Devices program, teaches you how, for the first time, to do a formal gait analysis. And it's interesting because this information and this procedure is not included in the AMA guides, although the AMA guides require it. So I provide such a procedure in the 3-hour program. So good luck with that, and I hope you enjoy and get that program. It's available from the website at www.easyqmece.com. To obtain the gait analysis in a practical manner that's quick and that provides a lot of information. And we're going to break down the gait analysis procedure into 5 simple steps. First is the observation. Second is the interrogation. Number 3 is the definition, or the defining of the gait disturbance if there is one present. Number 4 is a videotaping of the gait disturbance. And then step number 5 is the review of videotaping to evaluate that gait disturbance for consistency with other findings throughout the history and throughout the physical examination. So let's go over these here now one by one. In the observation of the injured worker, this begins the minute that you meet the injured worker for the first time. So your injured worker is going to be out in the waiting room. And as you come out to meet and greet the injured worker, you're going to observe for the presence or the absence of assistive devices. Now, large assistive devices such as crutches, canes, a cane, a wheelie frame, or a wheelchair, certainly those are going to be immediately obvious. But less obvious are small supports or small braces that could be hidden by clothing or that just escape your attention because of their size. Observe the manner by which the injured worker rises from the waiting room chair. Does the injured worker rise by pushing off their legs with their hands? If so, this is known as a positive minor sign. Do they rely heavily on the arms of the chair to push against? If so, this is a positive finding. Again, that would be another example of a positive minor sign. And minor sign, or this maneuver of pushing off the legs with the hands, that's used in an effort to spare lower back and lower extremity effort, and it's present in many lower back and lower extremity pathologies. And when this positive minor sign is present, it could be a sign consistent with a class 1 impairment in chapter 13, which recall stated that the person rises to a standing position, walks, but has difficulty with elevations, grades, stairs, deep chairs, and long distance. So difficulty with rising out of a deep chair, that would be manifest as a positive minor sign. That could qualify for a class 1 impairment, or could qualify for a class 3 impairment due to, and here's the definition of a class 3 impairment: rises and maintains standing position with difficulty. So you observe your injured worker to rise from the waiting room chair, and you make an assessment as to how difficult that is. Is there the presence or the absence of a minor sign? And you assess that, and you think in your mind whether that could qualify as a class 1 or a class 3 impairment. Then what you do is, what I recommend that you do is, you invite the injured worker to come back to the examination room, and you observe their movement from the waiting room to the examination room. And as they follow you to the examination room, what I do is I walk in front of them. I walk in front of them, but I walk backwards so that I can observe their gait. And I walk down the hallway to the examination room backwards while they walk with me forwards, and I observe their gait. Now, if there's no noticeable gait disturbance, in other words, you don't see any type of a shortened stance phase, you don't see any type of an antalgic gait, there's no sort of a Trendelenburg sign, I always question the injured worker, and I ask him, can you walk okay? Do you have any kind of limp? Do you have any kind of pain with walking? And I interrogate them about their gait. Sometimes they think I'm crazy, but I go through this with all lower extremity injuries, certainly, all spinal injuries, certainly, and even upper extremity cases as well. Now, if they answer in the negative, in other words, they say, no, I don't have any type of gait disturbance or problem, then basically the gait analysis is over. I mean, there is no further gait analysis. And then we simply proceed back to the examination room. If there is some kind of a noticeable gait disturbance, I question them and I ask them the same questions. I ask them, can you walk okay? Do you have a limp, or do you have any kind of pain with walking? And I confirm with them that what I'm seeing is actually a gait disturbance, and it's not simply some kind of compensation, perhaps for a poorly fitting shoe, for a stubbed toe, or for something else that does not qualify as a gait disturbance. And if I do detect some noticeable type of a gait disturbance, and the injured worker confirms that yes, indeed, they do have a limp or pain with walking, then that begins the formal gait analysis. And I immediately take the injured worker outside the building to a parking lot or to a long sidewalk, and we go through the formal gait analysis. And there's several steps involved with the formal gait analysis. And what you want to do is you want to observe the gait from at least 3 positions, and you want to be able to observe the gait over a substantial distance so that you can determine the consistency of the gait finding, and you can define the gait finding, and that requires a considerable distance where the injured worker is allowed to take several steps, at least 10 to 15 steps, so that you can detect and identify the pattern. So I observed the gait from at least 3 positions, from the front, from the back, and from the involved side. And for the purposes of this discussion, let's just consider that the involved side would be the left side. So for example, I would have the injured worker walk 20 yards towards me as I observe the gait from the front of the examinee. I would have the injured worker walk 20 yards away from me as I observe their gait from the examinee back. I would have the injured worker walk 20 yards while I observe the gait from the side of the affected limb. And the next step, once you identify some type of a gait disturbance or some type of labored or unbalanced movement, the next step is to define and characterize the observed disturbance with help from the injured worker. And I always ask the injured worker for their help to characterize what the problem is. I ask the injured worker to define for me what it is in their opinion that's causing the disturbance in the gait, and exactly what is the disturbance. Now, many times the injured worker themselves will help you identify the cause of the gait disturbance, and you confirm that their description of the cause of the disturbance corresponds to what you are observing the disturbance to be. And for any type of a visually noticeable gait disturbance that the injured worker describes to you and that you are able to observe on an objective basis, I always recommend a videotaping of the gait. And this will be this will be valuable to you later when it comes time to write your report. And when describing any type of a gait disturbance in my report, and especially if I consider it to be a bona fide disturbance in gait, I always indicate that upon request, and this is a quote I put in my report, upon request, I can produce videotaping footage of the gait analysis at the request of the parties. Now, I've never been asked to produce this footage, but in my opinion, having videotape footage of a gait disturbance makes the report and the description of the gait disturbance more substantial, because as the old saying goes, a picture is worth 1,000 words, and if a picture is worth 1,000 words, a videotape is worth even more. So again, like the observation of the gait, I would videotape the gait disturbance again from 3 positions. I would videotape it from the front as the examinee walks towards me, and make sure that you allow 20 yards for this, so that you can get a good repetitive pattern of the gait disturbance. Videotape also from the back, and then also videotape from the side of the affected extremity. When you get back to your office later, you're going to want to review this videotaping for consistency. Consistency meaning consistency with the history, consistency with the medical records. You're going to review your observed gait disturbance for consistency with known anatomy and physiology. And we'll get into a breakdown of the gait cycle here in just a minute. And you're also going to review the observed gait disturbance for consistency with your examination findings. And this is an important review, is a review for consistency. So just to review those steps, the gait analysis involves with observation, interrogation, definition, videotape, and review.
Just walking normal.
Okay, so let's go into Gait. Here's some video tapes that were taken from injured worker videos. Altered to protect the privacy of the injured worker. And what we're going to do is we're going to show these videos, and I'd like to demonstrate the importance of several of the principles that we've gone through so far, and I'll point those out as they become evident. Okay, so the question that I have for you, here we are, we're about ready to evaluate gait from an anterior view as the injured worker walks 20 yards towards us. So the question that I'm having for you as you watch this videotaping is this an example of normal or abnormal gait? Okay, so we'll begin our video tape here, and I'd just like to have you make a determination as to whether or not this is normal.
Just walking normal.
Doctors? Well, what we could safely say is if there is a gait disturbance there, whatever it is, it's subtle. And the one thing that stands out perhaps as an abnormal finding would be possibly a right external rotation of the right lower extremity, contributing to a foot flare on the right. Other than that, there are no major gait disturbances that I would report, and I suspect that you would probably state the same. Let me give you a little history on this injured worker. This is a 22-year-old male who had his left leg jammed between a metal pole and the forks on a forklift, and it resulted in a crush of the distal tibia and fibula. This required open reduction and internal fixation with the placement of screws and plates both in the tibia and the fibula. And these are the post-surgical scars. This is the fibula, scar over the fibula that has a plate and screws, and this is the scar over the tibia that had some reconstructive screws in place, and they're still in place, and they were in place at the time of this examination. So that is history. A different view. Let's see if we can identify disturbance involved. It's post-surgical. You can see he has a lack of dorsiflexion, which results in a shortened stance phase, especially on push-off phase. See how he gets off it, gets off it, gets off it. And it's interesting. I hope you caught that, doctors. He had a slightly shortened stance phase due to a lack of dorsiflexion at the ankle at the push-off phase. What about this case? Tell me, in your opinion, is this normal or abnormal gait? Is there gait disturbance at all?
And back.
Disturbance here, doctors? Lower extremity rhythm appears fine. How about upper extremities? It's absolute lack of arm swing. Would you agree? There's no arm swing. And notice the contracture of the right upper extremity. There's flexion contracture at the elbow, at the wrist, and at the fingers. And this is an injured worker who has a superimposed early tremor disorder, diagnosed as early Parkinson's disease, not yet manifest in gait disturbance of the lower extremity, but manifest as a disturbance in the rhythm of the upper extremity and loss of reciprocal arm swing in the upper extremities. And so the question you might be wondering is, does this qualify for permanent impairment as a gait disturbance? Well, the Parkinson's disease, of course, was non-industrial, but hypothetically, could disturbance in upper extremity function that results in a loss of reciprocal arm swing during gait, could that qualify for permanent impairment? Well, under the strict applications of chapters 13 and chapter 17, probably not correct. But under Alvarez-Guzman 2, I leave that to your imagination and your own judgment as to whether, in your opinion or not, loss of arm swing during normal phases of gait would qualify for permanent impairment or not. Certainly it results in a disturbance of gait because reciprocal arm swing is important. I think it would be safe to say that without reciprocal arm swing, it would certainly make running difficult, if not impossible. It would make walking fast difficult or not impossible. And so I simply introduce this here to stimulate your thinking. And later on we have another example of an upper extremity case. And so we'll refer back to the possibility of analogous impairments to Alvarez-Guzman as relates to the importance of the arms in the normal phases of gait.
Normalmente. Está bien.
Would be subtle at most. Would you agree, doctors? It would be subtle, if at all. Significant gait disturbance here, and when I questioned the injured worker as to whether or not, in his opinion, he felt like he had pain or limp or any kind of compensation for his gait, he denied that, even though he had a serious left knee injury where he had a direct contusion. He fell directly down onto his knee and aggravated some pre-existing degenerative changes and caused new injury to the knee. After a period of time, treatment and healing, the knee recovered most function, and while I found some permanent impairment for the knee, I did not find permanent impairment due to gait disturbance, and he was in agreement with that.
Esto es requerido
frontal thigh, lateral thigh pain, not posterior thigh pain, and no pain below the knee. Strictly left thigh pain. Well, safe to say that if there is a gait disturbance there, it would be subtle. There's not a major gait disturbance, but perhaps you could hallucinate that there was a slight shortening of the stance phase or something, perhaps. whatever it is, it would be slight. Following a lower back lifting twisting injury. Okay, what I found on this is I noted that there was a slight shortening of the stance phase on the left leg. However, when I reviewed this multiple times, over and over, I found that the shortening of the stance phase on the left leg was not consistent with every step. And on some steps it was absent, and on some steps it appeared exaggerated. And based upon the findings of the physical examination and some other historic inconsistencies, I opined that I did not find this to be a credible or consistent gait disturbance, and I did not provide permanent impairment for gait disturbance. This is a young woman with right shoulder and upper extremity injury, and she reports that she cannot hang her arm down to the side, and as a result that when she walks she has to hold on to the lapel of her jacket or put her hand in her pocket so as to avoid strain on tendons and tissues in the shoulder. And based upon physical examination findings, historic findings, medical records findings, and later findings of functional capacity evaluation, I found this consistent with the condition of her shoulder, and I opined for a gait disturbance under Alvarez-Guzman due to loss of reciprocal arm swing of the upper extremities. So interesting case there.